Welcome to this lecture on depositions and degenerations of the conjunctiva, cornea, and sclera. We'll begin with depositions and degenerations of the conjunctiva, then move into the cornea, where our discussion will be divided into three distinct layers: epithelial and subepithelial changes, mid and deep stromal changes, and endothelial changes. We will then have a very brief discussion on degenerations and depositions of the sclera. Finally, we will conclude this section with a discussion on drug-induced corneal depositions and pigmentations, highlighting common medications, their characteristic appearances, and clinical significance. By the end of this lecture, you should have a clear understanding of the patterns, causes, and management considerations for each of these ocular surface and stromal conditions, as well as the ability to recognize them in clinical practice. Let's get started on the first section that highlights degenerations and depositions of the conjunctiva. First, we'll discuss the changes that occur in the conjunctiva with aging, along with pinguecula. As we age, the conjunctiva can lose transparency and become thinner, especially in the interpalpebral fissure where it is more exposed to the environment. The substantia propria becomes less elastic, leading to conjunctival laxity, and the conjunctival vessels may appear more prominent, sometimes with saccular telangiectasias, fusiform dilations, or tortuosities. Pinguecula refers to a bilateral, yellow-white, elevated lesion typically found nasally on the bulbar conjunctiva near the limbus in the interpalpebral zone. It results from elastic tissue degeneration due to chronic environmental exposure, such as UV light, dust, and wind. Over time, pingueculae may enlarge, and recurrent inflammation is termed pingueculitis. Management includes topical lubrication and short-term corticosteroids if inflammation is present, with surgical excision reserved for chronic inflammation unresponsive to medical therapy or cases interfering with contact lens wear, but not for cosmetic purposes. A pterygium is a wing-shaped fibrovascular growth of the conjunctiva that extends onto the superficial cornea. The condition is strongly linked to UV light exposure, with other contributing factors including dust, wind, chronic irritation, and genetic predisposition. It is more common nasally where there is less obstruction of UV light. Risk factors include male gender, outdoor occupations, and living near the equator, and they can be prevented by UV protection through sunglasses or broad-brimmed hats. As the pterygium grows further onto the cornea, it can lead to astigmatism, corneal scarring, and formation of a Stalker line, a pigmented iron line on the corneal epithelium just central to its edge. It is important to differentiate pterygium from pseudopterygium, which arises after trauma, burns, or inflammation. Histologically, you will see elastotic fiber degeneration similar to pinguecula but with corneal invasion. The slide also notes that atypical features such as calcifications, leukoplakia, rapid growth, and irregular vessels may suggest ocular surface squamous neoplasia. Management primarily involves lubricants for irritation and avoidance of long-term topical steroids, with surgical excision indicated for progressive irritation, visual axis involvement, or motility restriction, and recurrence minimized by conjunctival autograft. As a clinical pearl, note that cataract surgery should be staged after pterygium excision to improve refractive outcomes. The left image shows a slit lamp photograph of a pterygium. The white arrow points to a Stalker line, a brownish iron deposition line that often appears at the advancing edge of the pterygium, indicating chronicity. The two right images are anterior segment OCT scans. In image A, the arrow indicates normal thickness epithelium overlying subepithelial fibrosis, characteristic of pterygium. In image B, the arrow points to a transition zone between normal epithelium and a grossly thickened epithelial layer, as seen in ocular surface squamous neoplasia. These OCT findings help differentiate between benign pterygium and malignant or premalignant epithelial lesions. The images show pre- and post-operative corneal imaging, illustrating the effect of pterygium excision on astigmatism. On the left, the power map, top, displays significant irregular corneal astigmatism, especially nasally, from a nasal pterygium. The corresponding keratoscopic image, seen on the bottom left, reveals distorted, irregular mires over the pterygium head, consistent with surface irregularity. On the right, the power map, top, taken 3 months after pterygium removal, shows a much smoother, more uniform corneal curvature, with a substantial reduction in astigmatism. The keratoscopic image on the bottom left now demonstrates evenly spaced, regular Meyers, reflecting improved corneal surface regularity and optical quality following surgery. This slide describes conjunctival concretions, which are small cystic lesions found in the palpebral conjunctiva. They are composed of epithelial or keratin debris, glycosaminoglycans or GAGs, and mucin. Clinically, they appear as small yellow-white dots, most common in older individuals or in those with chronic conjunctivitis or meibomian gland dysfunction. These lesions are usually asymptomatic, but if they erode through the epithelium, they can cause a foreign body sensation. Management depends on symptoms. Asymptomatic lesions are observed, while symptomatic ones can be simply removed at the slit lamp under topical anesthesia using a 25-gauge needle. The accompanying image shows multiple yellow-white concretions on the inner eyelid, consistent with the described appearance. Conjunctival epithelial inclusion cysts are clear or translucent cystic structures that develop in the bulbar conjunctiva or conjunctival fornix and are often found incidentally during examination. These cysts can be congenital or acquired, with the latter arising from the inclusion of conjunctival epithelium within the substantia propria, forming a fluid-filled cavity. Acquired cases may result from accessory gland duct blockage, chronic inflammation, trauma, or prior ocular surgery. In some cases, dilated lymphatic channels may mimic the appearance of cysts. While these lesions are typically asymptomatic, large or elevated cysts can cause ocular irritation. Management is usually observational unless the cysts are symptomatic, in which case treatment involves incision and drainage with a needle at the slit lamp, often with multiple punctures to reduce recurrence. Persistent or recurrent cysts may require complete excision for resolution. The next slide includes a video from the AAO that shows epithelial inclusion cyst incision and drainage.
Slit lamp examination, you will see a solitary conjunctival cyst. It is filled with translucent fluid and is not adherent to the square. Under topical anesthetic and using a 30-gauge needle, the cyst is punctured. These cysts can be multiloculated, much like a cluster of grapes. Therefore, several punctures with the needle are necessary to fully lance these cysts. While within the cyst, in a sawing motion, use the side, also known as the blade of the needle, to break the septae. By repeating these steps, you will help prevent reformation and reduce recurrence of these cysts. A blunt cotton tip applicator is used to confirm the cysts have been fully decompressed. Note, the redundant ballooned conjunctiva will regress with time as long as the cyst does not reform. Antibiotic drops are used after lancing to prevent infection.
Conjunctivochalasis is described as poor adherence of the bulbar conjunctiva to the underlying tissue, resulting in redundancy or folds of conjunctival tissue, which may cause irritation, tearing, or ocular surface discomfort. Vessel tortuosity and conjunctival hyperemia are nonspecific findings, meaning they can be associated with numerous systemic and ocular conditions. The included table categorizes possible causes into 4 groups: diffuse vascular tortuosity, for instance, blood hyperviscosity disorders, diabetes, and hypertension; segmented vascular tortuosity, for example, ocular tumors and pterygium; subconjunctival hemorrhage, like ocular surgery, trauma, and bleeding disorders; and telangiectasia, for instance, ataxia telangiectasia or hereditary hemorrhagic telangiectasia. The table emphasizes the wide range of potential etiologies spanning systemic diseases, local ocular conditions, and environmental or mechanical factors. This wraps up the discussion on degenerations and depositions of the conjunctiva, so let's now pivot and talk about degenerations and depositions of the cornea. Before we start the conversation of corneal degenerations, it's important to distinguish them for corneal dystrophies, as they differ in several key aspects. Degenerations often involves opacities in the periphery of the cornea, may be bilateral but asymmetric, and typically presents later in life. It usually has no hereditary component and may be associated with systemic diseases such as band keratopathy or sarcoidosis. The progression of degeneration can vary from slow to rapid. In contrast, dystrophies generally present with opacities that are centrally located, sparing the limbus. They are typically bilateral and symmetric, appear early in life, and are usually inherited. Dystrophies are generally not linked to systemic disease, and their progression is usually slow. Before we discuss degenerative changes related to pathology, let's first discuss the changes that occur in the cornea with aging. As we age, the cornea becomes flatter in the vertical meridian, which leads to against-the-rule astigmatism, and it becomes thinner, more rigid, and slightly less transparent. The refractive index increases over time. The decimate's membrane thickens progressively, from approximately 3 microns at birth to about 13 microns in adults. In older adults, peripheral endothelial guttae known as Hassel-Henle bodies may form. Additionally, there is a reduction in endothelial cell density, decreasing from around 4,000 cells per millimeter squared at birth to 2,500 to 3,000 cells per millimeter in later life. Coates' white ring refers to small, less than 1 millimeter, gray-white dots located in the superficial corneal stroma, often appearing circular or oval in shape and typically developing after a metallic foreign body injury. These lesions are composed of iron-containing fibrotic remnants. Once mature and free of inflammation, the lesions remain unchanged over time. They do not respond to corticosteroids or anti-inflammatory agents. Importantly, they are differentiated from corneal facets, which are small, gray-white epithelial defects in the anterior stroma, by their composition and origin. Spheroidal degeneration is characterized by translucent, golden-brown spheroidal deposits located in the superficial corneal stroma, Bowman layer, and/or anterior stroma. The conjunctival tissue may also be affected. These deposits are proteinaceous, not lipid-based. The condition can be identified clinically and confirmed histologically with protein deposition visualized using a Mason trichrome stain. Alternative names for this condition include actinic keratopathy, climatic droplet keratopathy, Bieti nodular dystrophy, and Labrador keratopathy. Primary spheroidal degeneration is characterized by bilateral deposits that initially develop in the nasal and temporal cornea and, with age, may extend to the conjunctival tissue in the interpalpebral zone. While uncommon, these deposits can occasionally progress across the cornea, forming a non-calcific band-shaped keratopathy, a presentation more typical in childhood cases. The condition is believed to result from UV-induced changes in the structural tissue or from abnormal extracellular material synthesis in the limbal conjunctiva. Importantly, this form of degeneration occurs independently of other ocular diseases. Secondary spheroidal degeneration of the cornea occurs due to underlying causes such as ocular injury, inflammation, scarring, or vascularization. Several risk factors are linked to its development, including genetic predisposition, actinic or sun-related exposure, extreme temperature fluctuations, and environmental trauma such as dust or wind. Management options are limited in their effectiveness. Medical therapy primarily involves lubrication, which may help improve even tear film distribution, but has otherwise minimal therapeutic value. Surgical interventions are often necessary for more advanced cases and can include superficial keratectomy, phototherapeutic keratectomy or PTK using an excimer laser, or lamellar keratoplasty in situations involving significant central corneal disease. Iron deposition in the cornea occurs at the level of the basal epithelium in areas where tear pooling is present, typically due to ocular surface irregularities. Its presence serves as an indicator of lesion chronicity, and visualization can be enhanced by using a cobalt blue filter before fluorescein installation. A well-known presentation is the Fleischer ring, where iron accumulates at the base of a cone in keratoconus. This should not be confused with the Kaiser-Fleischer ring, which is a copper deposit seen in Wilson's disease. Another manifestation is the Hudson-Steely line, a horizontal opacity found at the junction between the upper 2/3 and lower 1/3 of the cornea, often related to tear pooling from the lower eyelid. Iron deposition lines can also be associated with keratorefractive surgery, especially radial keratotomy. In most cases, no treatment is required. However, their presence can signal underlying pathology that may warrant further evaluation. Corneal deposits can occur in various layers of the cornea, each with distinct pigments, clinical findings, and characteristics. In the epithelium, iron deposits manifest as different patterns, including the fairy line, an iron line anterior to a filtering bleb, Fleischer ring, which surrounds the base of the cone in keratoconus and may also appear after keratorefractive surgery, Hudson-Stahli line, a horizontal opacity at the junction of the upper 2/3 and lower 1/3 of the cornea, and the Stocker line, which appears anterior to the head of a pterygium. The LASIK line is seen at the margin of ablation zones in the central cornea, with pseudoflacial rings possible after hyperopic ablation. In the epithelium and superficial stroma, melanin-like pigment known as alkaptin may indicate ochronosis, a condition characterized by the abnormal deposition of a dark pigment in various tissues of the body, which occurs peripherally in the metabolic condition alkaptonuria. Between the basement membrane and Bowman layer, oxidized epinephrine pigment can produce adrenochrome deposition, often associated with topical epinephrine use for glaucoma or with certain antibiotic therapies. Within the stroma, deposits may include iron from siderosis, carbon from corneal tattoos, or gold from chrysiasis, with the latter more often affecting the periphery. In the deep stroma and deciment membrane, silver deposits can cause argyrosis, presenting as slate gray or silver discoloration. At the deciment membrane, copper deposition may form a Kaiser-Fleischer ring in Wilson's disease or other hepatic disorders, or present as calcosis from copper-containing foreign bodies. Finally, in the endothelium, melanin deposits can create a Krukenberg spindle, typically appearing as a vertical ellipse and sometimes linked with pigmentary glaucoma. Band keratopathy is the degeneration of the superficial cornea characterized by the deposition of calcium primarily in the Bowman layer. It begins as fine dust-like deposits that are first observed peripherally at the 3 and 9 o'clock positions. Over time, these deposits progress and coalesce into a dense horizontal band across the interpalpebral zone, often leaving a clear zone between the lesion and the limbus. In the later stages, cracks may develop within the deposits, and small, lucent Swiss cheese holes can form due to nerve penetration. The underlying pathophysiology involves an imbalance of calcium and phosphate, which initiates calcium deposition into the cornea. The causes of band keratopathy can be divided into several categories. Chronic ocular inflammation is one of the most common contributors and includes conditions such as uveitis, juvenile idiopathic arthritis, chronic HSV keratouveitis, glaucoma, exposure keratopathy, interstitial keratitis, ptysis bulbi, and corneal dystrophies. Chemical exposure is another cause, with mercury fumes and phosphate-containing eye drops, such as pilocarpine or certain steroid preparations, as well as thiazide diuretics being known culprits. Systemic hypercalcemia is also a significant risk factor, often arising from renal disease, hyperparathyroidism, vitamin D toxicity, sarcoidosis, milk alkali syndrome, Paget's disease, multiple myeloma, or metastatic cancer to bone. Hereditary disorders such as Norrie's disease and congenital band keratopathy are less common but well documented. Other systemic diseases like discoid lupus, gout, tuberous sclerosis, and ichthyosis can be associated with band keratopathy. Additionally, other causes include trauma or surgical interventions such as aphakia with silicone oil, as well as certain tumors like iris melanoma. If no obvious etiology is noted, band keratopathy may require a systemic workup to rule out metabolic or renal disease. This evaluation includes checking serum calcium, phosphorus, and uric acid levels, as well as BUN and creatinine. Parathyroid hormone levels should be measured and urinalysis performed to look for crystals and assess pH. In cases where sarcoidosis is suspected, tests such as ACE, lysozyme, and a chest X-ray may be indicated. Management focuses on addressing the underlying ocular or systemic disease. Calcium deposits can be removed through EDTA chelation, which involves both mechanical and chemical methods. Following this procedure, a bandage contact lens is often applied, and topical antibiotics or steroids are prescribed to aid healing. PTK may be considered for residual corneal opacification, however, is not first-line treatment because the presence of calcium can affect the rate of ablation, thus may result in a severely irregular surface. Alternatively, mechanical removal of calcium plaques at the slit lamp can be performed using a forceps. Recurrence of deposits is possible, so repeat chelation may be required. This slide covers the white limbal girdle of Vogt, which comes in two distinct types. Type 1 presents as a narrow, whitish superficial band along the limbus, often resembling early calcific band keratopathy. The key detail here is that it leaves a clear, lucid interval between the girdle and the limbus. Histologically, there's degenerative change at Bowman's layer, creating chalk-like opacities with some small, clear areas. Type 2, on the other hand, looks like small, white, needle-like flecks at the nasal and temporal limbus in older patients. Unlike type 1, there is no clear zone separating the girdle from the limbus. Pathologically, it's linked to elastotic degeneration of collagen, similar to what we see in pinguiculae. From a clinical standpoint, neither form is vision-threatening and no treatment is necessary. Saltzman nodular degeneration is an idiopathic, often bilateral, non-inflammatory condition characterized by gray-white or blue-white subepithelial nodules, usually arranged in a circular pattern in the central or paracentral cornea. These nodules form due to localized replacement of the Bowman layer with hyaline and fibrillary material, similar in structure to the basement membrane, which leads to subepithelial fibrosis. The condition most often affects middle-aged and older women and can follow chronic ocular surface insults such as dry eye, chronic exposure, or long-standing keratitis. It can also appear at 3 and 9 o'clock positions in individuals who wear hard contact lenses. While many patients remain asymptomatic, some may experience irregular astigmatism, photophobia, or irritation. Management depends on severity. Mild cases are addressed with topical lubrication, whereas severe cases may require manual superficial keratectomy, with nodules being peeled away using jeweler's forceps. PTK is another option, though it carries risks of causing an irregular corneal contour or undesirable refractive changes. Recurrence is possible following surgical removal. The next slide is a video from the AAO that demonstrates a superficial keratectomy on a patient with Saltzman degeneration.
Under the operating room microscope, using topical anesthesia, the Saltzman nodule is visualized. This one is superior, and the patient is S-look toward their feet. Using a 64 beaver blade, the edge of the nodule is scratched enough to find the subepithelial plane beneath the nodule. A .12 forceps is used to grab the epithelium at the plane of the nodule and strip it off clean. Note, you can see the nodule on the retracted epithelium as it peels away. A bandaged contact lens and antibiotic drops were then placed on the eye.
This slide set shows Saltzman nodular degeneration before and after treatment with superficial keratectomy. On the left is the before picture, which shows multiple elevated gray-white nodules in the corneal surface, interrupting the smooth contour and scattering light on slit lamp examination. On the right depicts the after picture, where the corneal surface appears smooth and clear following superficial keratectomy with no visible nodules. The corneal clarity is restored and the overall contour of the cornea is more regular, indicating resolution of the lesion. Peripheral hypertrophic subepithelial corneal degeneration, PHSCD, is a rare corneal condition characterized by subepithelial fibrosis located adjacent to superficial limbal vascularization, sometimes accompanied by an occasional pseudo-pterygium. Clinically, it resembles Saltzman nodular degeneration, but without an underlying chronic ocular surface inflammation or keratitis. The condition is typically bilateral, peripheral, and symmetrical, occurring most frequently in Caucasian women. Unfortunately, corticosteroids provide minimal relief for affected patients. The picture on the right is a picture of PHSCD, which shows a slightly elevated whitish subepithelial band-like opacity near the limbus. The lesion appears to follow the arc of the corneal periphery and is located adjacent to the vascularized superficial limbal area. You can note the clinical resemblance to a Saltzman nodule. On this slide, we're moving into mid and deep stromal changes, focusing on corneal arcus. Arcus forms when lipid deposits accumulate in the peripheral corneal stroma, either just beneath Bowman's layer or closer to Decimet's membrane. This creates a characteristic hazy white ring at the limbus. It typically starts as arcs inferiorly and superiorly and eventually can encircle the entire cornea. Corneal arcus is more common in African Americans, in men, and its prevalence increases steadily with age. In fact, nearly everyone over 80 will have some degree of arcus, though it can also be seen in younger patients as congenital arcus juvenilis. A key clinical point is that in patients under 40, arcus may signal an underlying hyperlipoproteinemia with elevated cholesterol, so these patients warrant a systemic evaluation. Unilateral cases are unusual, and when they do occur, they may be linked to carotid artery disease or even ocular hypotension. Arcus is also associated with Schneider corneal dystrophy. For most patients, no treatment is required unless there's a concern for systemic disease in younger individuals. Crocodile Sjogren is a condition that presents as a bilateral corneal opacity with a mosaic pattern resembling crocodile skin. On closer examination, these appear as polygonal, gray opacities located at the Bowman layer, separated by distinct clear zones. From a histologic perspective, the Bowman layer is indented, forming ridges, and in some cases, there may be evidence of calcification. It is important to note that similar changes can also occur deeper in the stroma, particularly near the Decement membrane or along the corneal periphery. Despite its characteristic appearance, crocodile Sjogren is typically not visually significant and is often detected incidentally during routine examination. Moving on, we will now cover polymorphic amyloid degeneration. This condition is characterized as a bilateral, symmetric, and slowly progressive form of corneal degeneration caused by amyloid deposition. Clinically, the gray-white, refractile, crystalline opacities are found in the mid to deep stroma of the central cornea and can be viewed in retroillumination. The intervening stroma remains clear. This presentation can resemble early lattice corneal dystrophy, but it differs in both location and rate of progression. In most cases, vision is only minimally affected unless the disease becomes advanced. Importantly, there are no recurrent erosions associated with this condition. Next, let's discuss furrow degeneration, a type of degeneration involving the mid and deep stroma. This condition is characterized by peripheral corneal thinning, most often seen in older individuals, and frequently occurs alongside an arcus. The thinning is generally mild, but it can appear more pronounced over time, and in advanced cases, circumlimbal involvement may be present. Importantly, the corneal epithelium remains completely intact. There is no inflammation, no vascularization, and no associated risk of perforation. Because of this, vision is rarely affected, and no treatment is usually necessary. However, when performing cataract surgery, surgeons may choose a scleral approach rather than a clear corneal approach to avoid complications in the thinned area. Pterian marginal degeneration is a bilateral, painless, non-inflammatory, and progressive peripheral corneal thinning of unknown etiology. On clinical examination, the thinning most often starts superiorly and may gradually spread circumferentially, which can lead to astigmatism. Notably, it does not typically involve the central cornea. The corneal epithelium remains intact, and a fine pannus may cross the thinned area, with lipid deposition at the central edge of the vascular pannus. This condition is most common in individuals over 40 years of age and occurs more frequently in males. While spontaneous perforation is rare, it can happen after minor trauma. Additionally, acute corneal hydrops may develop in some cases. In terms of treatment, surgical intervention is indicated when there is significant astigmatism or risk of perforation. Surgical options include crescentic-shaped, lamellar, or full-thickness corneoscleral grafts. In cases involving 360 degrees of thinning, an annular lamellar keratoplasty may be performed. It is important to differentiate Pterian marginal degeneration from other peripheral corneal conditions. Fuchs superficial marginal keratitis typically occurs in children and young adults and has a different clinical course.
Peripheral ulcerative keratitis, or PUK, is another important consideration. PUK is characterized by epithelial defects and an absence of lipid deposition, and is often linked to systemic disease. In contrast, Pterygian marginal degeneration has an intact epithelium, features lipid deposition, and is not associated with systemic illness.
Now on to corneal keloids. These present as superficial, glistening white corneal masses, which may be protuberant and can, in some cases, involve the entire cornea. They are usually secondary to a vigorous fibrotic response following corneal injury or chronic ocular surface inflammation. However, they can also be congenital or primary and may be associated with congenital conditions such as Lowe disease. Clinically, corneal keloids may be mistaken for neurotrophic scars, Salzmann degeneration, or dermoids. For symptomatic cases, treatment options include superficial keratectomy, penetrating keratoplasty, or lamellar keratoplasty, depending on the severity and depth of involvement. Lipid keratopathy is characterized by yellow or cream-colored lipid deposits composed of cholesterol, fats, and glycoproteins located in either the superficial or deep stroma. There are two forms. The primary form is rare and occurs without any history of infection, inflammation, or corneal damage. The secondary form, which is more common, develops after corneal inflammation associated with vascularization. Examples include chemical injury or interstitial keratitis caused by herpes or syphilis. Occasionally, lipid keratopathy may be linked to focal stromal necrosis without significant inflammation. Treatment is generally indicated when there is decreased vision or cosmetic concern. Management involves controlling neovascularization with topical corticosteroids, using green laser for isolated vessels, and employing photodynamic therapy with veroporphin. Additionally, topical or subconjunctival bevacizumab can be used to reduce both neovascularization and lipid deposition. Now we turn to ICE syndrome, which represents a spectrum of findings including iris changes, pupillary anomalies, abnormal corneal endothelium, and peripheral anterior synechia. From a pathophysiologic standpoint, there is abnormal endothelial proliferation across anterior segment structures. These cells acquire characteristics of epithelial cells referred to as ICE cells. Contraction of these abnormal membranes can lead to pupillary and iris abnormalities. There may also be an association with herpes virus infection. When this abnormal endothelium migrates over the anterior chamber angle, it can cause synechia formation, resulting in outflow obstruction and eventually secondary glaucoma. Epidemiologically, ICE syndrome most often affects middle-aged women and is almost always unilateral. There are three main variants to keep in mind when looking at ICE syndrome. These variants can be recalled by using the ICE mnemonic. The first is iris nevus, or Cogan-Reese syndrome, where the abnormal endothelium spreads onto the iris, causing contraction and forming these elevated pigmented nodules. The second is Chandler syndrome, which is when the endothelial changes are limited to the cornea, leading to pump failure and corneal edema. And finally, we have essential iris atrophy, where the endothelium spreads onto the iris, causing progressive atrophy, chorectopia, and sometimes polychoria. You can see representative examples here at the bottom of the slide for each subtype. On specular microscopy, the corneal endothelium demonstrates large, pleomorphic cells with a reversed light-dark pattern compared to normal endothelium. Note on the bottom picture the light cell bodies with dark borders in normal endothelium, A, and dark cell bodies and white borders in ICE, B. This is characteristic of ICE syndrome. Confocal microscopy reveals pleomorphic endothelial cells with hyperreflective nuclei and bright cell borders. When corneal edema prevents adequate visualization by gonioscopy, ultrasound biomicroscopy, or UBM, can be used to detect angle changes associated with the disease. Management of ICE syndrome depends on the ocular structures involved. For corneal disease, endothelial keratoplasty is preferred. In cases where the cornea is scarred, penetrating keratoplasty may be required. For associated glaucoma, medical control is often difficult, and a tube shunt is generally preferred over filtering surgery. In advanced cases, particularly when there is repeated graft failure, a keratoprosthesis may be considered. When evaluating a patient with unilateral corneal edema, it is important to consider the differential diagnosis. Congenital causes include CHED, PPMD, birth trauma, and congenital glaucoma. Acquired causes include acute angle closure, Posner-Schlossman syndrome, corneal hydrops, herpes simplex or herpes zoster ophthalmicus, corneal graft complications, contact lens overuse, as well as aphakic or pseudophakic causes. On this slide, we're looking at peripheral corneal guttae, also known as Hassel-Henle bodies. These are small, wart-like excrescences that form in the peripheral descemet's membrane, caused by age-related thickening. They sit on the posterior corneal surface and protrude slightly forward into the anterior chamber. At the slit lamp, they appear as tiny, dark dimples in the endothelial mosaic and are best appreciated with specular reflection. It's important to note that these changes are usually considered a normal aging finding when present peripherally. However, if they extend centrally, that becomes pathologic and is strongly associated with Fuchs' endothelial corneal dystrophy, which can progress to stromal and epithelial edema.
Cornea farinata is an involutional change that may be dominantly inherited. It is characterized by delicate dot-like and comma-shaped opacities located in the deep corneal stroma, just anterior to the descemet membrane. These opacities form a flower-like pattern. They are likely composed of lipofuscin, a degenerative pigment associated with aging. The location is similar to pre-descemet corneal dystrophy, but in cornea farinata, the lesions are smaller and less varied. These findings are best appreciated with indirect illumination. Importantly, cornea farinata has no clinical significance. It is asymptomatic, although it can be mistaken for a progressive dystrophy. In the accompanying slit lamp image, you can see a narrow beam of light highlighting fine dust-like opacities in the deep stroma, producing the characteristic flower dust appearance just in front of the descemet membrane. Lastly, we will review causes of pigment deposition on the corneal endothelium. This occurs when melanin deposits on the posterior cornea and is most classically associated with pigment dispersion syndrome. However, it can also be seen in settings such as trauma, ocular surgery, or inflammation, for example, in uveitis. A pathognomonic finding in PDS is the Krukenberg spindle, a vertically oriented, spindle-shaped cluster of pigment located on the corneal endothelium. In addition to this, patients may also demonstrate transillumination defects in the mid-peripheral iris, as well as trabecular meshwork pigmentation. In the image shown, you can see the cornea and iris in full illumination. An arrow points to a vertical line of fine brown pigment granules along the central corneal endothelium, the characteristic appearance of a Krukenberg spindle. We are now going to quickly discuss degenerations and depositions of the sclera as we approach the end of this chapter. Age-related degeneration is characterized by a decrease in scleral elasticity, reduced hydration, and a loss of glycosaminoglycans. There is also subconjunctival fat deposition, which can produce a yellowish appearance of the sclera. A specific finding is the senile scleral plaque, also known as a Kogan plaque. This can present as either a diffuse granular or crystalline area or as a focal plaque located anterior to the horizontal rectus muscle insertions. Clinically, it appears as an ovoid or rectangular, grayish, translucent zone and may occasionally be mistaken for a pigmented tumor. This is represented by the image on the right. Histologic examination reveals a focal calcified plaque within relatively acellular collagen. These plaques are non-inflammatory and rarely extrude. We're now going to finish off this chapter by discussing this last and final topic, drug-induced depositions and pigmentations.
Drug deposits can occur through several pathways, via the tear film, limbal vasculature, aqueous humor, or due to a chemical affinity for corneal tissue. Clinically, patients may remain asymptomatic, or they may develop decreased vision, photosensitivity, and ocular irritation. In most cases, stopping the offending medication will lead to a resolution of the deposits. However, discontinuation is often not required, as the deposits are usually harmless and may not significantly affect vision. Cornea verticillata, also known as vortex keratopathy, is a condition that features whorl-like golden brown or gray deposits located in the inferior interpalpebral cornea. Common culprits include amiodarone, the most frequent cause, as well as chloroquine, hydroxychloroquine, indomethacin, phenothiazines such as chlorpromazine, and tamoxifen. Cornea verticillata is usually asymptomatic, though in rare cases it can lead to decreased vision. The findings typically clear with drug cessation. In a patient taking amiodarone or tamoxifen, consider optic neuropathy in cases with substantial vision decline and watch for potential retinal toxicity with aminoquinolines. In cases of vortex keratopathy, Fabry disease should also be on the differential. In the accompanying slit lamp image, you can see a pattern of fine, curved, spoke-like lines radiating from the central cornea, forming a whorl that is characteristic of vortex keratopathy. The deposits are subtly pigmented, creating the swirling appearance against the clear corneal background. Lastly, let's review other drug-induced corneal deposits and their characteristic features. Ciprofloxacin, when used topically, can produce a chalky white epithelial precipitate composed of ciprofloxacin crystals. Although white plaques predominate, a crystalline pattern can sometimes be seen. This resolves with discontinuation of the medication. Chlorpromazine leads to brown pigmentation. It enters the cornea through the aqueous, therefore the brown opacities are first found in the posterior cornea, including the endothelium, Descemet's membrane, and posterior stroma, and later progress toward the anterior stroma and epithelium. It may also deposit on the lens capsule. Clofazimine is associated with anterior stromal opacities or crystals. Isotretinoin produces fine diffuse gray deposits in both central and peripheral cornea. Gold salts are typically used in the treatment of RA. When used long-term with cumulative doses exceeding 1 gram, cause posterior stromal deposits that spare the Descemet membrane and endothelium. Rifabutin results in stellate refractile endothelial deposits, often beginning peripherally and migrating centrally. In the image shown, you can see the cornea under slit lamp examination with a dense, irregular, chalky white opacity with overlying crystalline deposits within the epithelial surface, representing a ciprofloxacin-induced keratopathy. Great job finishing this lecture. In this session, we explored the various depositions and degenerations affecting the conjunctiva, cornea, and sclera. We reviewed their clinical presentations, pathophysiology, diagnostic features, and management considerations, while also looking closely at key distinguishing points and relevant differentials. Take a moment to reflect on and digest this information. Understanding these conditions not only strengthens your knowledge base for exams, but also enhances your clinical acumen in recognizing subtle but important ocular findings. As always, the key to mastery is repetition and application. Review your slides, revisit the images, and think through the clinical scenarios in which you might encounter each condition. With consistent practice, these concepts will become second nature in both written assessments and patient care. See you in the next chapter.